Today, we'll be discussing a case related to recurrent patellar dislocation. So, how to diagnose and treat a patient with recurrent patellar dislocation. Our case is 27-year-old female with a chronic patellofemoral pain, weakness, and feelings of patellar instability. Now remember, she has chronic pain. It's not an acute event, but she has been suffering from this problem for quite a long time. At 14 years, there was a history of surgical lateral release with burst-ring sutures of the medial retinaculum on the left knee, disabled in daily life and sports activities. Now that means whatever happened started around at the time of teenage or probably in adolescent stage, maybe before that. She has undergone some surgery for the kneecap, and then she's still suffering from the same problem with chronic instability of patella. On further physical information we gained is that identical findings on both sides. Patella severely subluxed to the lateral side in extension, relaxed muscles, contraction of quadriceps muscles caused complete patellar dislocation. Now remember, this normal malalignment is normal alignment of knee is such that in extension patella remains the trochlear groove. But if it's coming out, this means patella, either the patella has something wrong with the patella or something wrong with the quadriceps, which is actually taking it out. And this is what is happening in this patient as well, that when she's contracting the muscles, it's actually leading to dislocation of patella. Apprehension test severely positive laterally, that whenever the patella is tilted slightly laterally, the patient feels that this is going to give way and it's going to come out. On moving knee joint passively from extension to 30 degree of flexion, the patella is reduced medially on the femur. Apprehension test now becomes negative. That is, when in slight flexion or in more than 30 degree of flexion, the apprehension test is negative. And when the examiner pushes the patella laterally, the patient does not feel that it's going to give way and cut out. But when the knee is in full extension, the patient feels that as the examiner is going to push the patella laterally, this is going to give way and it's going to come out and dislocate. And it remained negative with increased degree of flexion. Now, standing position showed normal static situation of the feet, excessive external rotation of the proximal tibia. There is a term called as miserable malalignment syndrome, which we'll be discussing in details later on. But if there is a tibia is in some form of external rotation, this means patella would be at increased predisposition of dislocating further. Tibia tubercle was positioned extremely laterally. Hip joint was normal. Whenever you have a problem with the knee, we must examine one joint above and one joint below, and usually foot and ankle and hip are normal. The patient can still have recurrent patellar instability. Now, when the radiographs were done, moderate lateral patellar dislocation on the left side was seen with partial reduction of patella with flexion. Severe lateral patellar dislocation on both sides with quadriceps contraction. So whatever it was, there was instability. Although usually patella remained inside the trochlear groove, but whenever either the knee went into extension or the quadriceps contracted, it actually dislocated patella out. So what are the further questions? Why she is having this kind of a chronic instability of patella despite having a surgery at the 14 years of age? What exactly is the diagnosis? Is it recurrent patellar instability? Is it recurrent patellar dislocation? Is it acute? Or is it miserable malalignment syndrome? What exactly is the diagnosis? What is then the treatment? As she is now 27 years of age, she is a healthy adult and she can go under some form of a surgery. Or does she really need surgery? Or some other form of mechanisms and some other options are available for us so that we can treat her? And what if we are going for surgery? What is the possible surgical treatment? Are we going for some sort of a soft tissue procedure? Or are we going for some form of a bony osteotomy?